Hi, I'm Jerry Hu, a PhD candidate from Norwegian University of Science and Technology. Here I present our work for left ventricular volume estimation in contrast-enhanced echocardiography using deep learning. Left ventricular volume estimation is important for heart disease diagnosis, treatment planning, and monitoring. And ejection fraction also relies on precise LV volume estimation. However, in clinical practice nowadays, LV volume or ejection fraction measurements face two main challenges. First, it often requires manual measurements, which is time-consuming and inconsistent due to variability of annotators' expertise. Secondly, conventional B-mode ultrasound may yield suboptimal images in patients with obesity or lung disease, potentially causing errors in volume estimation. Recognizing these challenges, we used contrast-enhanced ultrasound to address this issue, aiming to automate CEUS segmentation and volume estimation. Furthermore, we assessed inter-observer variability and compared its performance against automated B-mode segmentation. Finally, our goal is to increase diagnostic accuracy and improve patient outcomes. Our study included 105 patients with a collection of 492 contrast images of both apical two-chamber and apical four-chamber views, including diverse cardiac conditions. The annotations were contributed by a team of clinical experts. For each recording, the annotations were made by two distinct clinical experts for 2 to 4 frames. This included the end diastolic frame and one systolic frame, the end systolic frame, and an additional end diastolic frame. There are 72 patients that have B-mode recordings too, which were included for volume comparison. For the network architecture, we want to balance speed and accuracy to ensure clinical applicability. Therefore, we utilized a lightweight UNet model with 1.9 million parameters, renowned for medical image segmentation, which performs closely to bigger networks. The same network architecture was used in both B-mode and the CEUS segmentation. Segmentation accuracy and volume estimation were firstly evaluated to validate the performance of the network. However, in echocardiographic studies, our reference measurements are made from subjective annotations, and absolute ground truth for LV segmentation is not available. Therefore, we also investigated the inter-observer variability between two annotators on 85 frames from 33 patients. We measured their agreement using the DICE score. Further, we aimed to investigate and compare the volume differences between B-mode and CEUS for the same patient. To do this, we utilized an automated pipeline from our previous work that estimates LV volume from B-mode recordings. This pipeline detects key frames first as end diastole or end systole frames, then segment LV on those frames, and then determines the volume using a method called method of disk summation, which is usually used in clinical practice. We then compared these B-mode results to manual measurements from CEUS recordings. For our LV segmentation in CEUS images, the results were promising. We achieved an average DICE score of 0.92 plus minus 0.04, indicating a match between our predictions and the reference masks. Further, there's no significant differences that were observed between ES or ED frames and those outside the ES or ED, further attesting to the model's robustness. When we tested the model on a set of 100 20 frames from 23 patients annotated by a different annotator, which were not used in the training set. The CEUS segmentation network maintained an average DICE score of 0.92 plus minus 0.04, which suggests that the model agrees with both annotators. If you refer to this figure, we will see samples ranging from excellent to not so great segmentations for images. For the volume estimation, we found an average bias of 10 milliliter, which is minus 7%, and a standard deviation of 17.6 milliliter. This standard deviation can be contributed to either the segmentation errors or the variability in the reference data. We assessed inter-observer variability using the DICE score for annotations from two experts on 85 frames. We found a high agreement with a DICE score of 0.92 plus minus 0.03. However, when it came to volume estimation, there was a bias. On average, there was a volume difference of minus 13.5 milliliter, which is minus 10.5%, between the annotators, with a standard deviation of 13.9 milliliter. Interestingly, the inter-observer variability is comparable to the results of our automated segmentation algorithm. When comparing automated LV volume from B-mode to manual measurements in CEUS, we saw a mean bias of 4.4 milliliter, a higher standard deviation of 26.6 milliliter, which might due to unclear borders and segmentation differences. For example, we noticed differences in shape between B-mode and CEUS recordings for the same patient. As shown in the first case in this figure, we also can observe the volume differences bias from the blunt optimal plot, especially for large heart size. And also here are some examples for good average and poor segmentations in CEUS and B-mode images for the same patient. The upper row shows segmentation results from CEUS, while the green contour is the reference annotations, and the red mask represents the prediction results, and the lower row is the B-mode predictions. Our study shows that reliable left ventricular volume estimation can be obtained in contrast-enhanced echocardiographic images. Evaluating inter-observer variability helped to better understand the current acceptance in clinical practice, and thus provides an important benchmark for the automated approach. Our method's DICE score aligns with this variability. Even though the volume estimation standard deviation was higher, there was still comparable to inter-observer variability as seen in the blunt outline chart. In the last images, we see some examples where the B-mode images are unclear for borders, while the contrast segmentation network managed to segment accurately on CEUS, which shows the potential use of our approach. However, we still encounter some challenges. First, the observed bias in volume estimation, especially the differences in between B-mode and CEUS volume measurements. Second is the generalization ability. Our initial study was based on a limited dataset from a single center and vendor, which may not be representative of broader clinical context. Therefore, for future work, we should expand our data to multi-center and multi-vendor for further evaluation. Meanwhile, when comparing the automated LV volume acquired from B-mode to manual measurements, the standard deviation is notably high, especially for larger volumes. So In future work, MRI could be used as a reference to assess the performance of both B-mode and CEUS images. In conclusion, our proposed approach achieves promising accuracy in LV segmentation and volume estimation in contrast images. Our study demonstrates the potential of LV volume estimation using contrast echocardiography images. Offering automated LV volume estimation for both CEUS and B-mode images could enhance the robustness of results and broaden its applicability in clinical practice. Thank you for your attention.